Hello, everyone. I hope you're all doing super well. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about aortic dissections. Now, aortic dissections are not very common, and they are not a very high yield concept for your year. However, you will still see this come up on exams, and this really goes hand in hand with aortic aneurysms, which is the next lecture we'll be covering in this series. Now, aortic dissections aren't a super high yield topic when it comes to your third year matrix. However, it's still one that's really important to know, especially because of how it can present. And you should have a good understanding of the different types and I guess the different ways you can manage those different types. So starting off nice and easy, well, what is an aortic dissection to begin with? Some conditions that you will hear about would be dissections and aneurysms, and it's good to have a good understanding of what the two are and how they differ from each other. So what happens with an aortic dissection is you obviously have the aorta, which is shown here, and the aorta has a few layers, right? You have the tunica intima, which is the innermost layer, and it's endovascular. Then you have the tunica media, which is superior to the intima. What happens with aortic dissections is you end up with a small tear in the tunica intima. This serves as an entry point for blood to escape from the intimal layer to the intimal medial space. So this would be the space between the tunica intima and the tunica media. Ideally, there should be nothing in this space. It should be an empty or a false cavity. However, with high pressure blood entering this tear, you can have a development of a false lumen, and that in essence is what an aortic dissection is. So that raises the question as to, well, why do you have the initial tear to begin with? And there are a few things that may cause this, but the most common one that's seen with most patients is hypertension. Now, as you can imagine, with high pressure blood, over time you end up developing weaknesses in the intimal layer, and this is partly age-related as well as with the development of atherosclerotic plaques. But you can have a weakness, and that weakness can be made worse with hypertension. You can also have some rarer causes like trauma, and this in particular refers to sudden deaccelerations. You can have an inflammatory picture that has caused inflammation and a tear in the lining, or you can also have congenital bicuspid aortic valves, and this can put you at a high risk for developing these tears. So once you have the tear, as I mentioned, you start accumulating blood in this newly formed false lumen, and over time that ends up growing in size, and you end up developing a hematoma, which affects you negatively in two ways. Firstly, it's obviously taking blood away from where it should actually be going, and secondly, as you can see here, as the hematoma grows in size, it's going to start compressing on the true lumen, and you're going to have reduced blood flow, or reduced peripheral blood flow, which is obviously detrimental as well. So where does this usually happen? So obviously aortic dissections are going to happen in the aorta, but where exactly in the aorta are these dissections? And it's good to know about where the exact site is for a few broad reasons that I've mentioned here. The first one is that both of the main systems that we use to classify aortic dissections are based on the presence or based on the location of the dissection itself. Secondly, the treatment modality as to whether we opt for a surgical approach or a more conservative medical approach also depends highly on where the actual dissection is. And thirdly, some dissections, depending on where they are, can be picked up better by one imaging modality over the other, and we'll go through this as well. So the two broad systems that I mentioned earlier refer to the Stanford system and the DeBakey system. More commonly, we tend to use the Stanford system, which is this type A versus type B system, which we'll talk about in a second, versus the DeBakey system, which is not very commonly used. And I'll go through why the Stanford system is more pragmatic in a way. So where does this actually happen? Answering our question, well, most aortic dissections tend to happen in the ascending aorta, and those would be referred to as a Stanford type A dissection, affecting 65% of all dissections. You then have dissections affecting the descending aorta, and the anatomical cutoff for this is that they should be beyond or distal to the left subclavian artery. And then you can also have actual dissections within the aortic arch itself. So here is kind of a visual representation of that. So a type A aneurysm is one that involves the ascending part. So if you have a dissection that involves the ascending part, regardless of what else it involves, that automatically would be classified as a Stanford type A aneurysm. Versus if it's just the distal, depending on how distal it is, that would be a type B. The reason that's important when it comes to treatment is that type A aneurysms almost always require surgery. Now, this is going to be an open surgery to replace the dissection with a graft. So by actually repairing the inner lining and using an endovascular graft, we can prevent further blood flow from accumulating in the false lumen, and we close the lumen surgically as well. Versus type B aneurysms, which are often managed more conservatively. We often aim to optimize that blood pressure, which is often going to be present with such patients. And finally, we may also use vasodilators to optimize peripheral blood perfusion and ensure that they're medically stable. And it does not often require surgery. Going back to how they actually present, so obviously this is going to be really important to identify an aortic dissection when a patient is in front of you. So it typically is known to present as a sharp tearing pain that often moves or radiates to the back. You can also have interscapular pain, neck pain, jaw pain, and if the dissection is in the abdominal aorta, you can often present with abdominal colicky pain that radiates to the back. Now, a question arises to, well, why does the pain radiate or why does it migrate? And if we go back to our picture here, as you can see, it starts off with a single tear, right? But over time that can spread. And as it tears through the cavity between the tunica intima and the tunica media, that would cause pain, which is why it often presents as a migratory or a radiatory pain. In addition to the pain itself, the patients may often present with complications that arise from obviously the hemodynamic instability that they may present with. So this can include hypotension, syncope, diaphoresis, as well as inguinal pain. All of this is important in terms of managing the presentation itself. If someone obviously presents with hemodynamic instability, our threshold for treating them surgically and rushing them to an OR is going to be much lower if they present with relatively low levels of pain and are hemodynamically well. So then the question arises, well, what do we order and what investigations do we use in what circumstances? And this is where things can be a bit tricky. So the choice of investigation typically depends on a few things. So what is our pretest probability and how hemodynamically stable is the patient? What the pretest probability means is it's a complex way of just saying, based on the patient in front of you, based on the story that they've told you, based on your examination, how likely do you think an aortic dissection is going to be? Now, if you have a low pretest probability, we would rather use an investigation that's good at ruling something out, right? Versus something, if we suspect that they almost certainly have an aortic dissection based on how typical the story is, we might go for an easier investigation that's going to be more useful and quicker in just confirming our diagnosis so we can move on to management. The preliminary investigation for most cases is going to be a chest x-ray. This is primarily because most dissections tend to be in the ascending aorta, and those would be picked up in the chest x-ray. And what you would see with these cases would be widening of the mediastinal space. And as you can see, this is quite widened. The threshold for which is usually 8 centimeters. In saying that, we also learned that a lot of aneurysms can be in the a lot of dissections can be in the descending part of the aorta. And yes, technically some of these would still be picked up. However, a dissection in the abdominal aorta is obviously unlikely to show up in a chest x-ray, which is why we may often consider a CT angiography that's a bit longer to do, is more expensive, but can provide more in-depth information on the extent of the dissection, the exact location, and the degree of compression of the lumen. As you can see here too, we have a dissection that has started obviously in the ascending part, but the false lumen extends all the way down into the abdominal aorta. Now, this will not be seen on a chest X-ray. On a chest X-ray, you would just see this part. Well, you'd see that there's mediastinal widening, and you might suspect, well, this might be an aortic dissection. The additional information is only going to be seen on a CT angiography. And this is really important when we go in surgically, because we want to know the exact depth or the degree of the dissection. Lastly, if the patient is unstable, and this may often be if there's been a rupture in the false lumen, in that case, you might opt for a transesophageal echo. It's not going to be as specific and might not give you a lot of information in terms of the degree or the extent of the aneurysm, but is a really quick way in just confirming the diagnosis, in which case you then rush them to the OR and try to manage their bleeding, manage their blood pressure, and repair the wall as quickly as possible. Some important complications to be aware about. Obviously, they might have a rupture because we have a situation where there's blood in this false lumen. Obviously, that's not a lumen that's meant to contain blood, which means it's going to be much weaker and more prone to ruptures. You can also have myocardial infarctions. Now, this is a tricky one because in my head, I don't really see how an aortic pathology should cause a myocardial infarction, right? But if you think about it, if you consider the carotid sinuses from where the coronary arteries arise from, they are right at the base of the aorta, right? If you have a dissection that's extending into the root of the aorta, that is obviously going to compromise cardiac blood flow or flow to the coronary arteries. Secondly, in addition to the fact that you now have a reduced supply, if a person is hypotensive and hypoperfused peripherally, your heart is going to try to compensate by a reflex tachycardia. So now you have a heart that is contracting faster than usual and therefore would require more oxygen. At the same time, you have a system where you aren't able to provide enough blood flow to the cardiac myocytes themselves. So the imbalance of the supply demand puts you at high risk for myocardial infarctions. Aortic regurgitations, again, with the extension of the false lumen backwards, if it invades the root of the aorta, you can often have aortic regurgitation. And that's quite commonly a valvular complication that might be picked up on a physical examination. You can have cardiac tamponade if the extent of the blood flow goes into the pericardial space. You can end up with strokes because this false lumen puts you at a much higher risk of thromboembolic events. And lastly, with any rupture, you can bleed into the thoracic or the abdominal cavity. Lastly, I've not mentioned this here, but with a compromised blood flow, you obviously run the risk of hypoperfusion and ischemia down the track. So anything that the aorta supplies might undergo ischemia. So you may have renal infarcts, gut infarcts, and ischemias, and so forth. I hope that all makes sense. I know we went a bit quickly through that, but if you have any questions, as always, feel free to get in touch with me. This is my email. Feel free to get in touch with me on Facebook as well, or you can just drop a comment and I'll try to get back to that. And as always, please look after yourself and please look after your loved ones. I'll see you guys next time.